Hello everyone, welcome to session 2, which is health of marginalised populations. So the presenters from this session will be discussing how they've successfully adapted their approach by considering the patient challenges when engaging with testing and treatment. So our very first session presenter is Kevin Marriott, who's the Director of Programs of Hepatitis Australia. Kevin will be discussing the lived experience of people with hepatitis C with a specific focus on identifying the less obvious patients who need care. Thank you, Kevin.
Good morning, Bianca, and thank you to Ashton for inviting me. I'd just like to acknowledge that I'm talking to you from Yagara land here in Brisbane, and acknowledge the traditional owners of the land and pay my respects to elders past and present. So I'll just share my screen with you. So today I'm talking a little bit about the people who are actually living with or impacted by viral hepatitis, in particular hepatitis C, and looking at engagement with care and some of the barriers that exist around some of that. So a little bit about Hepatitis Australia. We're the national peak organisation for viral hepatitis, and we represent our 8 state and territory member organisations, so who are all non-government organisations, as well as the interests of people living with or impacted by viral hepatitis, that being hepatitis B and hepatitis C. We sit on a plethora of committees and advisory groups around the country in terms of informing policy and health service delivery. But also we have a public profile that we use to facilitate access to hepatitis information for the community, and that happens through our online platforms, website, social media, and we facilitate the National Hepatitis Information Line, which people can call and they'll be referred to the hepatitis organisation in the state and territory they're calling from. So who are we talking about? We're talking about 130,000 people who are currently living with chronic hepatitis C in Australia. Greg might have given you some new information on that this morning, so I'm not sure if you've had that. But essentially we're talking about people with current or recent risk factors for hepatitis C transmission, but also those people who have a historical risk for hepatitis C. And I'll also touch briefly on those people who may have been partially diagnosed. So people with current risk factors. So effectively we're talking about people who inject drugs, particularly if they've been engaged in sharing injecting equipment. We're also talking about people who have a history of incarceration. Prisons are a priority area in terms of hepatitis C transmission, but also hepatitis B. And also people with recent tattoos, not such a huge issue these days, but something still to consider, particularly if they've had tattoos done in unsterile situations such as backyard tattoos and the like. So as you can imagine, that paints a pretty stereotypical picture of what hepatitis C might be about, which is actually not the case in most situations. We end up with a lot of assumptions around this particular group in that they may appear to be low functioning, where in fact most of these people are actually quite high functioning. And all of this leads to an environment of stigma around hepatitis C. Another thing to consider with this particular part of the population is that there's a need for regular testing. So looking at whether or not people who may not already have contracted hepatitis C, but they may be at risk of contracting it. But also the fact that hepatitis C, you can be reinfected. So people with ongoing risk factors need to be monitored if that's the case. In relation to the non-current risk factors, so essentially we're talking about people with a historical risk for hepatitis C. And this group makes up around 2/3 of the people living with hepatitis C in Australia. Most of these people may have had some historical injecting drug use, even if that was just experimental use. And we've certainly heard situations where people have said that it might have just been 1 or 2 times that they've actually shared equipment but have contracted hepatitis C. People who have had tattoos done, the old scenario that we'd always talk about that is, you know, people who've gone on holidays and got a tattoo in Bali, where the situation may not necessarily have had good infection control. but also people who had previous medical treatment overseas. So we did see quite for a little while there that there was a lot of people actually going over for affordable dental and cosmetic surgery, but those situations may not have been that sterile. So, and people who have had blood or blood products prior to 1990, although most of these people will have already been followed up. The other group that we need to think about is people from high prevalence countries who might have migrated to Australia. Southeast Asia in Australia features quite highly within that group. The interesting part of this group, though, is that most of these people are likely to be in their 50s, 60s, 70s, and in some cases even the 80s. So they're not necessarily your typical presentations that you might expect coming to a practice. The other thing to think about with those people who are partially diagnosed, and Greg Dorr may have touched on this already, is that people who were tested quite a long time ago may not have had a PCR test to follow up to actually confirm whether or not they have the virus. So there's a possibility that there's people living out there who think they have the virus but may in fact not have it. So it's important to look at follow-up testing. This graph is one you may have already seen today, or one similar to this. This is actually the number of treatments for hepatitis C that are prescribed each month. And as you can see, that has declined significantly over the time since hepatitis C was listed. The current regimens were listed on the PBS. So this is quite concerning. So you would think that in an environment where we have hepatitis C treatment readily available and readily accessible through GPs and even nurse practitioners being able to prescribe, that there wouldn't be some barriers, but there are. And as you can imagine, through thinking about those stereotypical views around hepatitis C and what I've talked about in terms of those population groups, stigma and discrimination does feature quite highly. There's been considerable research in Australia looking into this, and unfortunately most commonly experienced in actual health services. So that's something we need to look to address. We're also asking people to disclose unlawful activity, so particularly around injecting drug use. So we need to create an environment that allows people to do that. And as you can imagine, with people who have moved on from their injecting drug use or experimental or had those tattoos early on, that we're actually talking to people about disclosing behaviours that they may not necessarily fit in their current perception of their life. They might have moved on considerably from that space. The other thing is there's a lack of awareness around hepatitis C and the fact that a lot of things have changed around that. Public awareness campaigns are limited. We've certainly done some, but they're not necessarily resourced sufficiently to actually get out at a high level within the public. And as you can imagine, in the recent environment, there's been difficulty trying to promote any health awareness campaigns beyond COVID. So. The other thing to think about is too, with people who may have current risk factors, that hepatitis C may not be figuring as a high priority as something to deal with in their life. So that's something to talk about, and I'm sure Josh will allude to some of that as well. So how do we talk about increasing engagement? So effectively, you can look at what happens within your practice, and that's about creating an enabling environment. So nothing new, something we talk about quite a lot. And it's about increasing awareness amongst all of the staff in clinics, about having information readily accessible so that they don't actually have to ask for information about hepatitis C, that they can just access it, and ensuring privacy. As I said, there's sensitive discussions that people are having, so they need to feel comfortable about that. The other thing is that you may look at contracting with the hepatitis organisation in your state or territory. They do provide training in most situations that can be done for staff wherever you're working. And they'll usually include some lived experience as part of that as well. They can also facilitate referrals, and most of the organisations will have some form of list, whether or not that's on their website or not, about where they can access hepatitis C treatment. However, the big thing that I think we need to think about, and no doubt will come up in other presentations, I assume, is the need to do case finding. As we know through the recent research around COVID and the impacts of COVID, that we've certainly seen hepatitis testing decline during that time, and it's yet to actually get back to the pre-2019 levels. And as I mentioned, also that decline in hepatitis C treatment initiations as well. Those levels are well below what we need if we're actually going to achieve the elimination of viral hepatitis in Australia by 2030, which is the current goal. The other thing to think about with this is that you can also think about hepatitis in the sense of liver cancer and liver health screening. The hepatitis B and C are the leading, the highest contributors, I guess, to liver cancer and liver cancer related deaths in Australia. So in terms of lived experience, I've got a couple of case studies here, and then that'll be followed up with a video of somebody talking about their personal experience. So this is Jack. Jack was with his housemates in 1981 and they came down with jaundice. He didn't, and he didn't therefore get tested until 1993. So living quite a while, not knowing whether or not he'd been at risk or not. There were times when he felt that he was exhausted and just basically putting it down to getting older and that the stress of his job. Unfortunately, that's a very common scenario when you think about the age groups that we're talking about as well, in that many people just think that they're just getting tired when in fact it could be the impact of liver damage, or the hepatitis C virus itself. So in spite of his anxieties, he admits to being a terrible patient, but rarely actually looked at getting his liver monitored. After a while, obviously in 2016, once the treatments became available, he took 8 weeks of treatment and was cured. So the outcome of that for him, he identified as basically being a situation where he'd cut his hand at work and realised that he actually didn't need to disclose that he had a bloodborne virus at that point in time. So that was the moment of realisation for him. Then we have Jane. Jane is a 68-year-old mother of 2, grandmother of 3, diagnosed in 2010 and cured in 2016 after the current antivirals became available. She contracted hepatitis C during the late 70s, early 80s, experimenting with IV drugs. And that was seen as something that she didn't think was that unusual at that particular time in her life. But realising that there was no public awareness around bloodborne viruses during that time either. She found it extremely confronting to be diagnosed, and that was mainly because she had left that life behind and that she'd actually even given up alcohol, but this was actually something that had come back to haunt her. So this is actually something that, these situations are not things that are uncommon. They happen quite often, and if you want to hear or look at other stories, personal experiences, you can actually go to either of these websites as well. And I will just show you the video, so I'll hand you over to Linda, who will share her screen and provide you with that video.
I'm Rob Surrett. I'm 56 years old. I carried Hep C for 20 years and I've been cured for 3. In 1987, I got a tattoo, and that I haven't used intravenous drugs or anything like that. It's the only way I can think. I've never had a blood transfusion, so it's the only way I can think of that I got it. 1990, I was working in Queensland, and the particular place I worked at, the blood bus used to come around every couple of months, and everybody would go and donate blood. About 2 weeks later, in 1990, I was diagnosed with Hep C. I got a letter from the Red Cross saying thank you for your donation, but they didn't really name what it was, but they said we strongly advise you see a liver specialist straight away. I thought that it was very important that I told my family about it and that I told my work colleagues about it, because the main way of contracting the disease is blood to blood. Back then, there wasn't really any treatment. There was the interferon, but at that stage I wasn't sick enough. In 2011, when my second daughter was born, I had a FibroScan, and they found that I'd basically gone to stage 2 cirrhosis of the liver, and the doctor said that I'd be very lucky if I saw my daughter's 5th birthday. So I said to myself, I'm not going to let this thing beat me. I'm going to do everything I can to make sure I'm here to see my kids grow up. Alfred contacted me and said, look, we've got this new wonder drug. It's got a 98% strike rate. There's the first generation is just about to be put on the PBS, but we want to give you the Rolls-Royce 4th generation to see how it goes. And I'm their golden guinea pig. It was just one tablet a day for 12 weeks. Simple, no side effects. It was fine, yeah. And the first set of blood tests that came back were perfect. Now it's like, yeah, I'm surfing as much as I can and spending as much time as I can with my daughters and still trying to cram as much in as possible. My liver's back to basically a normal, healthy liver again. And I'm as happy as Larry, and so are my family. The advice I'd give to people that think that they may have it, or that they've gone and had a tattoo back in the 80s or 70s or whatever, or they have used intravenous drugs, it doesn't matter. It doesn't matter, it's about your health and your family's health, and that's the most important thing. Hepatitis Australia is running this new campaign, Test, Cure, Live, where you can have a blood test, have the cure, and live your life happy and safe.
Excellent. Thank you, Kevin, and also thank you for sharing the video, Linda. If you've got any questions for Kevin, we do have a dedicated Q&A at the end of the session. We can ask questions to Kevin and the other presenters. So I will now pass on to our next session presenter, who's Dr. Joss O'Loan, who's a general practitioner of the Combi Clinic and Medico Inala General Practice. Joss, I'm all tongue-tied today. Joss will be presenting on hepatitis C and point of care testing in an outreach setting. Thanks, Joss.
Beauty. Thanks, Bianca. I'll just get my screen up. Here we go. Hope everyone can see that okay. And thanks, Kevin, for the great talk before me. Like Kevin, I'm also in Yagara country and like to pay my respects to elders past, present and emerging. So today I'm going to talk about the Combi Clinic and also talk about point of care testing that we've got our hands on. It was sort of mentioned in the earlier forum, earlier session. So talk about how we're using it and the places that we're using. So in terms of the reason that we sort of set up a mobile outreach model of care was around, the barriers that we found as GPs, myself, Matt Young, another GP that set it up with me, around difficulties getting patients onto care and the problems with getting them there. So, many patients that we saw or still see live very chaotic lives and lots of competing priorities, which means that their health isn't always put at the top. So simplifying the process is really important. Getting investigations like blood tests and driving around trying to find an ultrasound is often really out of reach of many of the patients that we find. And accessing services, literally just trying to get to the specialist appointment, physically get there is often a barrier too far. The bus fare, the parking tickets, and of course then the stigma that many people often feel, and it's real that they do feel this in accessing services for hepatitis C. So there are a few barriers to accessing treatment, but these are barriers that we can break down. Got the Berlin Wall up there for a reason. When that was up, we thought we could never get past it, or it would never come down, and lo and behold, it is. So we really do need to move beyond these traditional models of care and really go out into the community and bring services to them. Which brings me to the other, breaking the myth that there is such thing as a hard to reach patient. And I often say, and some people might have seen this slide before, unless you're getting winched out of a helicopter, you can't describe a patient as a hard to reach patient. It's the system that's hard to navigate for the people trying to access the system. And if the system's hard to navigate, we'll change the process so people can access it. And there's lots of other examples like this in Australia, which is fantastic, for changing the service so that people can access it. You look at the Headspace model for young people's mental health, you look at Aboriginal medical centres, there are a lot of different, changing the model to suit the patient rather than expecting the patient to come to me. And if you're going to change the model, you may as well get a combi van because, why not get a combi van? So, driving forward and talking obviously to a GP forum, I feel the role of eliminating hepatitis C in Australia is really left up to general practitioners. As Greg and previous presenters have pointed out, GPs are really picking up the game in terms of prescribing. And that's really important because these patients are walking into our clinics. These patients are seeing GPs, and Hep C is now such an easy disease to treat that we need to start doing it as core GP business. Those graphs that Greg was sort of showing, and there's another similar graph, the low-hanging fruit, the patients that were already worked up and sorted and warehoused and in the gastro clinics have all been treated. The job now is to go out into the community and find patients that are undiagnosed, or find patients that think they might have it or at risk of having it, get them screened and link them into care. So the way that the combi approach is it's really a one-stop shop approach. We have a GP consult, we do a blood, we do a fibroscan, all at the one time, and we have a fast turnaround to get patients onto scripting. So this therefore limits loss to follow-up. Lots of patients that we see are homeless or have all those other barriers of quite itinerant lifestyles. So getting them to a script and getting them on the pills is really important, because this may be the only medical consult they have for the next few years. And it's really important that we get on them and get treated so we can cure the disease, so it doesn't develop into cirrhosis and all the horrible outcomes that comes. And we do it in a really laid back way. We reduce the stigma by wearing Hawaiian shirts. We drive around in a combi. We play some awesome music, and we have a bit of a festival vibe when we turn up. So it's not your traditional white van medical clinic. We go all over, homeless shelters and drop-in centres, drug and alcohol clinics, needle syringe programs, probation parole, community festivals, and a couple of jails. So really, there's no amazing secret to it. If you look at the data where people that are high risk of having hepatitis C or contracting hepatitis C are going to frequent, well, let's go to them rather than sort of sitting in my office and expecting them to book an appointment and walk through the door. Actively going out and trying to find them. The revolution was the DAA therapy, but probably the next revolution is point of care testing. So as was mentioned before, the GenX Cepheid machine came on TGA approval late last year, and it's brilliant. It's fantastic. You're able to do a Hep C RNA off literally a drop of blood on your finger. If you can do a blood sugar, you can do a GenX machine. Maybe it's a little bit more complicated, but in effect, and from the patient point of view, and that's what really matters, it's a click on the finger, and you get a result back in an hour. So for places we go, a homeless drop-in centre, and this photo was taken at a venue where they've got foods and showers and washing machines. So we'll click their finger, they'll go and have a meal, they'll have a shower, they'll come back, they'll get the result. Amazing. And it's really simple. Patients love it. A lot of patients that we see, and I'm sure you guys see, with a past history of injecting drugs, fear needles. Their veins might be scarred or problematic to access. And so to be able to say to someone, hey, look, I'll do a drop of blood and then I'll be able to tell you, is revolutionary. It's fantastic. So yeah, TGA last year, Medicare rebate for it hopefully will be coming soon, because that's the thing that will be able to make it sustainable. And that's the thing that we really need to drive for. So we got hold of this machine in November last year, and we've been crying out for one. So we really took up and ran with it. So we've done a couple of projects with the GenX machine. So we ran a screening blitz at our regular GP clinic, and a regular GP clinic, we see Matt and myself do methadone and Suboxone prescribing. So we see about 200, 250 patients on opioid replacement therapy. Over a month, we managed to collect test 157 patients. 13 of those came back positive. 5 were new diagnoses and 6 were reinfections. And we thought we'd done a pretty good job in terms of screening and treating prior to this. So it shows that a lot of our patients, in terms of the reinfection, are still at risk and still need ongoing treatment. The 5 diagnoses, important, were predominantly patients that knew they had Hep C, but we're never able to get a formal phlebotomy for it, and had literally been waiting for this Hep C check to come along. Obviously, lots of negatives, and also really important for this machine is the ability to do SVR for it to prove the point that they are now cured. So we're pretty great to sweep the GP clinic. We've also taken it obviously out on the combi and tested a whole bunch of other patients at other venues where we go to. And getting back to that point of reducing the loss to follow-up, we're able to start, almost half the patients on the same day. So we'll finger prick them, prove the diagnosis, fibro scan them, assess their liver, and then start them on treatment. And a big chunk within a week, if we need to do other bloods or whatnot. And of course, just to reiterate, the fact that you can then prove for SVR cure as well is really important. And it's portable, it's light, it's easy, you can carry it anywhere. The other thing we did is we've done a couple of elimination blitzes at a few prisons around southeast Queensland. So Palin, Women's and Helena Jones Centre. So we're able to go in over a weekend and test the entire facility for hepatitis C with a drop of blood on your finger, being able to give same day results to the patients and getting on to treatment straight away. So again, blitzing the prison, coming in, finding it, and again, patients love it. It's really great. It's really good. So a bit of tips of how to get started. So you obviously need music. So there's a QR code to a really good Spotify playlist. That's always important. You need fashion, and you do need a great team. I mean, you need enthusiasm for a lot of this kind of stuff. You need to get out there. You need to sort of spread the gospel of curing hepatitis C. And it's great fun. I'm sure, as all the presenters in the video before, this is really quite amazing opportunity to change a person's life and to change the course of Australia. So, the take-home message: simplification is key. Point of care testing, if you can get your hands on it, get your hands on it. It's the next revolution. There's no reason why, in a PHN setting, we can't have a point of care machine that rolls around to different GP practices every month, and you get a go that month, you screen your patients and it rolls on. We need to make the process as easy for the patient as possible to make sure that uptake is there. Engagement is vital, creating a safe, warm, welcoming environment for the patient. Stigma is a really significant thing. The role is to get the medication into the patient's mouth. And that's the social challenge that we've really got with hepatitis C. The science behind it, the medication behind it is already done and dusted. It's how do we create that environment that patients want to engage with. And Hep C, elimination is life-changing. A huge impact for the patient. So this is a photo of a patient of mine. And I think it says it all. The end of Hep C means life. And that's him with his family, with his grandkids, showing that, this is a big impact for him, and his family. And it's great. And really, it's a tectonic shift in the medical landscape. And GPs are really at the forefront of creating this elimination change. Really passionate about the fact that Hep C elimination is not going to be achieved in the tertiary hospitals. It's going to be achieved in the community clinics, and it's going to be GPs that are going to really drive the force. So that's me done, and my spiel. And thanks for Asham for having me on board.
Well, thank you, Joss. I'm going to move on to the next session. Thank you very much for your presentation. So the next session presenter is Dr. Seema Basil. She's a general practitioner at Warren-Curra Health Service. So Seema will be presenting on hepatitis C in an Aboriginal medical service and rural and remote settings. Thanks, Seema.
Good morning, everyone. Just sharing my screen. So I'm going to be talking to you about a remote AMS perspective, diagnosing, managing, and treating Hep C. So before I tell you a bit about Roburn, I'd like to pay my respects to elders past and present and future. This is Ngarluma country that I work on. So Warren-Curra Health Service is 1,600 kilometers away from the nearest gastro or hepatology service. And we look after a population of about 3,000 ATSI people. So why is it important to be looking for Hep C in Aboriginal communities, and in particular remote communities? If we look at the stats, even though only 3% of the Australian population identifies as ATSI, 11% of new Hep C cases each year in Australia occur in ATSI people. So it's estimated that there are around 200,000 Australians with Hep C, and of those, 22,000 are Indigenous. Remoteness adds an extra layer of complexity to things. Data from the 2015 to 2017 census showed that life expectancy for ATSI women and men living in remote locations was reduced by up to 7 years when you compare them with Indigenous people living in major cities. And this would also include death from end-stage liver disease. And what's even more worrying is the alarmingly higher rate of infections in Indigenous people under the age of 25, who are 6 times more likely to be infected than their non-Indigenous counterparts. Young Indigenous people, especially males between the ages of 15 to 35, are a really difficult cohort to engage with primary care services. Some of the strategies we've used to try to connect with this group have been things like opportunistically offering a health check when a client attends the service to support a partner who's undergoing antenatal care. We'll just flexibly fit them in. We've also worked with the local hospital so that ED presentations of clients who normally wouldn't come to see a GP will get BBV screening done in ED. So we've talked about the significantly higher rates of infection among ATSI people, but what are the reasons for this? Obviously, socioeconomic disadvantage is definitely right up there. We know that antisocial behaviors, mental health problems, and substance abuse are more rife in marginalized groups of society. Indigenous people also have higher incarceration rates, which are associated with an increased risk of Hep C infection, and I'll talk about that a bit more in the next slide. There's also a higher level of needle sharing, and there's lack of access to needle exchange programs here. In Roebourne, all the services are quite spread out, and our city centre is about 35 kilometres away. There's a small nurse-run hospital in Roebourne where you can get clean needles and syringes, but it's actually quite inaccessible for people. About 6 months of the year, it's very hot over here. So to even walk 100 meters to the hospital, it's not going to happen. And the other thing is, people are afraid of going to the hospital to get needles when maybe a relative might be sitting in the ED waiting area, waiting for treatment. So I wanted to make mention of incarceration rates because the statistics associated with contracting Hep C whilst in prison are really frightening, with some estimates sitting at nearly 30%. This means that nearly a third of people in the criminal justice system at any one time have or have had Hep C, and ex-prisoners tell stories of one needle being shared between 10 to 20 people again and again and again. In the year to July 2020, The Guardian reported that there had been nearly 12,500 ATSI people in prison, and very sobering numbers indicate that the conviction rate for ATSI people per 100,000 is almost 2,000, while it's only 166 for non-ATSI people. Well, what did we do at Mount to address the Hep C issue? I have to admit that when I first came to work here in late 2013, I had really little clue about infectious diseases. I'd come straight from London, but the team started to realize quickly that we had to move out of our comfort zone because logistically, it's just so much harder to get access to specialist services. In 2014, we started doing routine BBV and syphilis testing. This was really innovative because we started this before the Pilbara syphilis outbreak. We made Hep C serology testing part of routine health check bloods that were done with every ATSI health check, every GP management plan, and where previously missed with team care arrangement reviews. And surprisingly, majority of patients were really happy to be tested. It was really rare that someone said no. They also want the reassurance of knowing that there's nothing nasty lurking. I wanted to show you a comparison of how our testing rates nearly tripled after implementing this screening strategy. In the 7 years prior to 2014, 1,500 Hep C serology tests were completed, but in the 7 years after 2014, 4,300 have been performed by implementing screening. The other way that we sought to broaden our reach with Hep C testing was to collaborate with local mental health services. There were a number of patients with severe mental illness, especially drug-induced psychotic illnesses, who weren't attending the AMS. They were engaging regularly with mental health, getting their depot injections, but as far as they were aware, they were seeing their doctor every month. So we created a dedicated time for shared care clinics with mental health. We collaborated on our management plans and we pooled our resources. For example, if the AMS couldn't get hold of a patient for HCV RNA levels, or if the patient kept missing ultrasound appointments, we'd ask the mental health team to help us out. This relationship building effort meant that we found Hep C in 3 psychiatric patients, all of whom have undergone treatment and are now cured. We also work closely with the local drug and alcohol detox facility. So when a new client, who might not even be one of ours, comes in, they come to the AMS for a health check, and that's a great opportunity to perform BBB screening. So the results over the last 10 years, we've had a total of 73 positive cases of Hep C. That's from January 2011 to January 2021. And of those, 57 have been detected since 2014, when we implemented BBB screening. Over 40% of patients have cleared the virus spontaneously. But here's the winning data. Nearly a third, 22 patients, have had treatment, and 15 of those treatment courses have been provided here, directly in the health service. 7 were treated in Perth, because that was before PBS listing of DDAs. 12 people moved away after testing positive, and we've had no further follow-up with them. I can only hope public health have been able to find them. And amongst this group were 3 people who'd moved out of the area, who'd accessed our service prior to entering rehab. 1 patient has been non-compliant with 3 separate courses of treatment. And we currently have 4 newly diagnosed or returning patients who are positive and awaiting further investigations before treatment can commence. We don't have access to fibroscan here. And there's a 6-week wait list to get an ultrasound. So in summary, the results, this is what makes it all worthwhile. So since 2014, we've supported 15 patients to achieve a cure from Hep C. They don't have to worry about Hep C-induced cirrhosis or dying from liver cancer. As GPs, how often do we get the opportunity to tell a patient that a chronic condition that they suffer from is now cured? I mean, this is priceless. It brings such great satisfaction to the practitioner and untold joy to the patient. And all of this was achieved without a single one of these patients having to travel to Perth to see a specialist. Their blood tests, scans, prescriptions were all organized by the GP. They didn't have to take time off work or worry about having to explain to colleagues or supervisors that they had Hep C. They were just able to carry on with their lives as normal. And my final slide is some useful tips. These are the 3 things that I would consider to be really helpful when you're trying to manage Hep C in the GP setting. Firstly, build a relationship with your local gastro or hepatology service. Knowing that there's a specialist there to support you if you've got complex patients or you're uncertain about prescribing will help increase your confidence. We have a great relationship with the liver team at Sir Charles Gardner Hospital, and I can email the liver nurse if I have any questions. We send them the remote Hep C consultation forms if the consultant needs to sign off. This can happen within just a couple of days, and it beats having to wait for outpatient gastro. Secondly, keep a database of your Hep C patients so you know where they're at along the journey from diagnosis to treatment cure. These patients can often have lifestyles that result in them disappearing for a while. So if you have a list of all your patients, then it's easy to identify who's been lost to follow up. And thirdly, Select a dedicated nurse who manages your Hep C portfolio. That way you know things actually get followed up, like ensuring all the required blood tests are taken, ultrasounds are attended, monitoring of bloods is done during and after treatment, and that the correct recalls are put in the patient's records. Thanks, that's all from me.
Thanks, Seema. It was really great to hear, I guess, hepatitis C testing in an Aboriginal community where mostly the focus is on Hep B. So that was really fantastic. Thank you. So our final session presenter is Dr. Thai Ruvarenga Jayani Thai Rumugan. Apologies if I've not pronounced the name correctly. And they are a general practitioner at Pimpama. Oh, I'm very tongue-tied today. Pimpama Medical Centre and Gold Coast Primary Health Network. Gianni will be presenting their abstract case discussion, Chronic Hep C GP Perspectives. Thank you, Gianni.
Hello, everyone. Good morning. And thank you, Bianca and the ASHRM organizing team for this great opportunity today and for letting me share my tiny bit of experience of treating chronic Hep C infection in a general practice environment. So let's move on to my patient, David. Thanks, Linda. Next slide, please. Next slide, please. Yeah. Thank you. So David is a 57-year-old male truck driver who's spent most of his life in Queensland. So he presents initially in the year 2017 with an intermittent right-sided upper abdominal pain of 2 weeks duration and also intermittent neck and low back pain of 3 years duration. So he was actually more concerned about his neck pain and back pain rather than his tummy pain. The abdominal pain was mostly confined to the right upper abdomen and stays there, and it's not associated with any changes of appetite, weight changes, bowel opening, and no history of fever. And he was more concerned about a long-standing tiredness, which obviously affected his work as a truck driver, and he had to take a lot of time off from work. And he had a past medical history of chronic hepatitis C infection diagnosed 10 years ago. So interestingly, it wasn't treated before. And he also reports of a moderate intake of alcohol and hazardous intake of cannabis use. And also reports of a history of tattooing, which was done locally, and denied in intravenous drug use. And he was separated from his girlfriend 6 years ago. And currently he's living with his brother, who he thinks also has chronic hepatitis C infection. Next slide, please. So on examination, he appeared tired, and we found his body mass index was 30.12. He wasn't pale and not icteric, and there was hardly any signs and symptoms of peripheral liver stigmata. And mental state examination was quite unremarkable with a low mood, and his musculoskeletal examination also was like unremarkable with just a limited range of movements in the neck and the lumbar region. And his neurological examination was also unremarkable for most. Next slide, please. So we did some initial investigations, and on presentation, his full blood count was almost normal, except a little bit of borderline red cell macrocytosis. His sugar levels were normal despite his age. He wasn't a diabetic, and his initial kidney functions were normal as well, which was a good thing for management. Next slide, please. And his liver function, except for the ALT level, which was slightly elevated, the rest of the liver functions were normal. And there was a slight reduction in the HDL levels, but otherwise his cholesterol was normal. Next slide, please. So we discussed and got this permission to do a sexually transmitted infection screen, and his HIV levels were negative. He was negative for hepatitis A. Interestingly, he showed inadequate immunity for hepatitis B, and Hep C antibodies were positive and confirmed his past history. So we further followed up with a Hep C RNA PCR, which was detected, and with a genotype of 3A. We also did a Hep C quantitation, and luckily his alpha fetoprotein levels were normal. And the ultrasound abdomen and FibroScan, he showed early liver cirrhosis. Thank you. Next slide, please. Yeah. So what problems we encountered in this patient? So David had a treatment-naive chronic Hep C infection with genotype 3A liver cirrhosis. Also some degenerative changes in the cervical and lumbar spine, moderate alcohol consumption with hazardous use of cannabis use, anxiety, depression. So mostly about the treatment and also some personal issues, obesity, and metabolic syndrome. Next slide, please. All right, so I agree with the speakers before me. So the stigma and the discrimination. So these are the, main reasons for the treatment hesitancy. So in fact, if it could have been treated like 10 years ago, he wouldn't be like this. The early cirrhosis would have been prevented. So what could be the reasons? As the speakers before me mentioned, the stigma and the discrimination. Lack of knowledge about his condition, go inside, and the needle phobia. He was scared of getting injections as treatment, and he was also scared about the adverse effects of the medications. And obviously, unfortunately, David was not discussed about the management options or the treatment strategies, and his focus was more on the pain and the fact that he couldn't attend work and he had to take more time off from work was a big issue for him, and the fatigue which prevented doing his activities of daily life. Next slide, please. So, of the 227,000 people living with hepatitis C in Australia, only 82% have been diagnosed. And many of these people have either not been informed of the diagnosis or not aware of the implications of the chronic viral hepatitis. So this is from the NPS Medicine Wise 2017. Next slide, please. So what's the risk for liver cancer for David? So according to the specialists at the Gold Coast University Hospital, it's 3% per year. So David was, we had a discussion and this was informed to him as well. Next slide, please. So what's next? What did we tell him actually? So we told David, look, the treatment is easy. And if he gets rid of it now, it'll be like that he never had it before. So that was so simple. So the mention of the term, or there are like oral DA treatment available. So he was so happy and so he started like listening to us. Next slide, please. So what we actually did, the advice and support. Whenever possible, we grabbed the opportunity to advise him on the treatment strategies and got his support. And importantly, we addressed the specific needs of the patient. So in this case, the pain. So as long as he suffers the pain, he's not going to listen to us, or he's not going to listen to whatever we say about getting treatment for chronic Hep C infection. So first we had to address his back pain and the neck pain. So we referred him to the pain specialist, get that sorted. And then we vaccinated for Hep B. And then a motivational interview about his alcohol and cannabis addiction. That worked well, referred to Lives Lived Well program. And we asked him to be followed up regularly at these mental health support services. And also we made sure that he visited the GP practice at least like every 2 weeks for advice and treatment adherence. And most importantly, we referred him to the specialist care at the Gold Coast University Hospital for initiation of the treatment. Next slide, please. So what are the benefits? So I won't waste your valuable time. So this is all mentioned by the speakers before me. Next slide, please. So in relation to David, it's obviously to reduce the progression of liver cirrhosis, reduce the risk of liver cancer. So that's the 3% risk in his situation. And reduce the need for liver transplantation and improve the quality of life and improve his neurocognitive functioning and reduce his cardiovascular risk. Obviously, he is actually having metabolic syndrome as well. And finally, to reduce the all-cause mortality that can be contributed by the cardiovascular risk, not only chronic hep C infection. So treating chronic hep C infection indirectly treats the other chronic illnesses as well. So reduce the transmission of hep C infection is very important. So by treating one patient, we are doing a great service to the nation as well. Next slide, please. So this hospital initiated him on sofosbuvir and daclatisvir for 24 weeks. And as we discussed, there were minimal drug interactions because he was only on simple analgesics like paracetamol, Nurofen, and Mercindol. So they didn't pose any problems in the treatment. And he wasn't started on antidepressants, so that's good. And the psychological counseling really worked and improved his mood symptoms. So exciting news was at 12 weeks post-treatment, his HCV-RNA PCR was not detected. So he attained SVR at 12 weeks post-treatment. So that's very exciting. And we let him know that even though he was treated, he's still not immune protective and there's a possibility of reinfection. So he understood that as well. And we were able to attain the alcohol abstinence after 18 months. That's a very exciting news as well. And he also cut down a lot of cannabis intake as well. And he was followed up by the hospital team every 6 months for hepatoma surveillance. And we made sure that we did blood at the end of every 4 weeks and until he got treated, that's for 24 weeks. And then after that, every 6 months, we repeated these blood test results as well for a year. Next slide, please. So finally, his post-treatment renal functions, the liver remained same. He didn't deteriorate further. And he reported improved energy levels and mobility. And he was able to resume his exercise routine. He was able to go for evening walks. And his pain improved quite significantly. And we were even able to target some weight loss, which was great. And so that means reduced cardiovascular risk. His mental health improved tremendously. And obviously that helped with reducing the stigma as well. And finally, he was able to tell his brother to go for treatment, so which was great news for the family. Next slide, please. So curing a chronic illness, as Seema said, is an enormous job satisfaction for all the GPs. So I agree. And the take-home message. So collaborative management is important and it's 100% successful. And I agree with Josh that we should, as GPs, lead this mission. And a holistic management approach is also very, very essential because it's not the fact that we are treating chronic hep C. It's important for the patient to participate in the treatment. So it means we should address his other concerns as well. So as long as he's worried about his finance or his pay, he's not going to listen to us. So it's important that we should pay attention to other aspects of his problems. And so that's pretty much about David. Thank you for your patience.
That was really great. Thank you, Gianni. Also, thank you to all of our session presenters. And now we'll move on to a Q&A. We've got a few questions that have come through. So I'll pose these to the different panelists and you can answer as you can. So we've kind of got a combined question for Joss from Erin and Nada. So Erin's was, hi Joss, how do you access meds on same day and how much was the point of care testing machine? And following from there, Nada said, is the negative PCR on the point of care testing enough to prove SVR? No need to rebleed. And wonder if you have any partner pharmacies who have on-site meds.
So I'll go backwards because, so in terms of SVR recording, so a Gen-X result is as good as any other result. So it's a TGA approved result. So if it's negative, it's negative. It's positive, it's positive. So it is as good as it is. You don't need to do formal phlebotomy. Interestingly, I mean, the machine that it actually is, the Cepheid machine, often they'll have it in the lab. So in the lab in the big hospital, they'll often run that Hep C test on a Cepheid machine in the lab. They've just got, you know, a 64 one and we've just got a 4 one. So we've got a mobile one. So it's exactly the same technology that they'd use in a normal lab. In terms of getting same day scripting, so in terms of initiating treatment, it's in same day handing the patient the script on the same day. And then there's the, a chemist that they normally go to. So your horses for courses in that regard. So if a patient's on Suboxone or Methadone or regularly picking up a bunch of other meds and they've got a good relationship with that chemist, we'll strongly encourage they go to the chemist they've already got a good relationship with, and then flow through there. So in terms of getting pill into the mouth the same day, unfortunately, we're not quite there yet. It's about getting the script to them the same day, and then they'll go to the chemist. Liaising with pharmacies and those kind of things. So there is a project we're just about to start up where we get a 10 pack, so like a starter pack for your medication, and we'll be able to give them a Webster pack of 10 tablets, 10 days worth, and then the script. So they'll be able to start the same day, and then that'll give them 10 days to get to the pharmacy to then cash the script and the pharmacy to bring it in. So we do have that available. Like with everything, it's logistics. So trying to work out pharmacies and relationships and all that kind of stuff, but it is possible to do it, and that should hopefully be coming soon. The other question about cost, yeah, that's the real issue. So at the moment, pharma is funding the cartridges for us, and Greg was sort of alluded to it, Greg Dorr, in his presentation. It doesn't have a Medicare rebate yet. And this is the real kicker. So if Labides or QML or whoever your private pathology is runs a Hep C check for an RNA, I think they get something like 140 to 180 bucks from Medicare or something like that figure. The cartridge, costs somewhere between $60 to $80. So there is a cost issue there, and money to be made if someone can work it out. And that hopefully should happen, which means that then sustainability of the machine can go on forward. The actual machine itself is about $30,000. So a lot for a GP clinic to purchase. But if you're thinking of a PHN to purchase the machine, and then you share it around a group of GPs or alcohol and drug clinics or whatever, that's when the scale becomes usable. So a couple of steps to overcome in terms of Medicare, but good things, there's good change, in terms of point of care testing. HbA1c just got money to be given to GPs to do point of care testing. So hopefully it'll come, but we'll see how we go.
Thanks, Joss. We have another question from Bernadine to Gianni. So how did the risk of liver cancer per year, how was that calculated?
So yeah, actually, so we were like discussing with the hospital team, So that was mentioned by the specialist, the liver hepatologist. So I'm not sure how the calculation was made, but that's what been told by the specialist in relation to this particular patient. Yeah, sorry about that.
That's okay, no worries, thank you. And a final question for the session, it appears, is for Seema. So this is from Nada. So hi Seema, fantastic talk and love the reflex partner testing with antenatal checks. What time frame do you have for the blood results? And is there a good relationship with the prison to follow up with your patients and vice versa?
Thanks Nada, with the turnaround of blood results, 24 to 48 hours, which, you know, sometimes is a bit too long. You might not find the person, but yeah, we're lucky in the AMS setting that we have outreach workers and transport officers, so we're pretty good at finding people. In terms of the prison, we used to have funding for a prison program, which the doctor didn't actually go there, but we had a programs team that went there and could connect these patients with us as soon as they were released from prison. But unfortunately, we lost that funding a few years ago. So at the moment, they have private contractors that are providing GP services. The Hep C testing has probably fallen by the wayside because 2013, 2014, there was a visiting liver team that would come up twice a year and they lost their funding as well. So I have actually, interesting you asked, because I did actually start up a conversation with the prison about 4 weeks ago, because we want to be able to get in there, even if it's just once a month, you know, send a GP and get some more holistic services, get them to know us as well, so that when they're released from prison, they know where they're going to come. So yeah, watch this space. We'll see.
Thanks, Seema. So that was the final question that we had for the Q&A. So, Nada has just snuck in a quick one. We have 3 minutes for the session. Nada is on it. So there is much opportunity. Is there much community resistance to NSP? I know there may have been in Port. Does that make sense, Seema? To you, is there much community resistance to NSP? I know there may have been in Port Hedland.
Oh, okay, Port Hedland. No, there isn't actually. There isn't much resistance. People are generally, in fact, one of the things that's been really interesting is amongst patients who've told us, who we know are IV drug users, they actually have this reverse sense of comfort about using intravenous drugs, because they know that now you can get a cure for Hep C. So I've had a couple of patients actually speak to me about, well, I'll come later because I know you guys have the pills that can cure me if I have anything wrong with me. But yeah, generally, we've had one patient who has failed to comply with 3 courses of treatment. And this is the kind of case where I discuss each time with gastro. And I don't know, if he decides he wants to try a 4th time, we'll clearly have to have a discussion because of the funding, but yeah.
Thank you. So I think we'll finish the session there. So a big thank you to all of our session presenters. So Kevin, Joss, Seema and Gianni for your time and sharing your presentations. So we're going to have another 10-minute break and then we're going to be having our next session, which is Hepatitis C Care Practical and Financial Strategies Workshop, which is led by the General Practitioner Advisory Panel. So we'll see you all at 11:15 a.m. Australian Eastern Standard Time. Thank you.
Thank you.